A red, scaly rash, it's got to be one of the most common reasons people go to the doctor. But figuring out what's actually causing it can be surprisingly tough. It's like a genuine medical detective story, and today we're going to follow the clues.
So, when a patient walks in with some mysterious rash, how does a doctor actually solve the case? Well, it's not just about taking a quick peek. Nope. There's a whole method, a kind of code they follow, to read the story that the skin is trying to tell.
And that's exactly what we're going to do in this explainer. We are going to crack that code together. We'll walk through the systematic approach doctors use to turn those visual clues into a confident diagnosis.
Okay, let's dive right in with our first case. I want you to meet Mr. H. He's a 36-year-old teacher, and he comes in with this red, scaly rash on his lower back. It's been bugging him for about 3 weeks, and the moisturizing lotion he's been trying, yeah, that's not doing a thing.
But hold on. Before we can even think about diagnosing Mr. H, we got to understand the tools of the trade. A proper dermatologic exam isn't just guesswork. It's an algorithm. It's a step-by-step process that makes sure nothing important gets missed.
And here it is. This is the 6th-step algorithm. Think of it like you're building a suspect profile for this rash. We start with the basics, right? Where is it? How many spots are there? How big are they? Then we get more specific, noting the color, figuring out the primary lesion type, and finally, mapping out the overall pattern. Each step gives us another critical clue.
Now, that 5th step, identifying the primary lesion, this one is absolutely crucial. And here's the thing, it's not just about what you see, it's about what you feel. Is it totally flat? Doctors call that a macule. Or is it raised? If it's raised and small, it's a papule. If it's raised and bigger, it becomes a plaque. That simple difference you can feel makes a world of difference in the diagnosis.
Okay, so on top of that primary lesion, we start looking for secondary clues. Think of these as things that happen to the rash over time. Is there a buildup of scale? Is there crust from, say, dried fluid? Has the skin gotten all thick and leathery from scratching? These little details tell us about the rash's behavior and its history, filling in really important parts of the story.
All right, toolkit assembled. Let's get back to Mr. H and apply this algorithm to see if we can crack his case. Okay, let's run through our algorithm for Mr. H's rash. Location? Check. The gluteal cleft and his knee. Size? We're looking at up to 30 millimeters. The primary lesion? We can feel it. It's a raised pink plaque. And the key secondary feature? That classic silvery white scale. See how a really clear picture is starting to form? And when you line up all those specific clues, the well-defined pink plaques, that classic silvery scale, and the locations on the knee and lower back, well, the diagnosis becomes crystal clear. This is the textbook signature of psoriasis. So what is psoriasis really? Well, this is the important part. It is not just dry skin. It's an autoimmune condition. What that means is the body's own immune cells, these T cells, get confused and start attacking healthy skin. This just kicks skin cell growth into overdrive, and they pile up to create those characteristic plaques. So what about treatment? When a doctor picks a topical steroid, it's not just about the medicine, the vehicle. The stuff it's mixed in is just as important. For thick plaques like the ones Mr. H has, a strong ointment is great because it helps the medicine really sink in. But in sensitive areas like skin folds, a doctor would probably pick a gentler cream. It's all about matching the treatment to the specific spot. Now, psoriasis has this famous cousin it's always getting mixed up with, eczema, also known as atopic dermatitis. At first glance, they can look really similar, but our diagnostic toolkit is perfect for helping us tell them apart. All right, let's put them head to head. Psoriasis plaques, they usually have these sharp, well-defined borders, and they love extensor surfaces, like the outside of your knee. Eczema, on the other hand, often has these blurry, ill-defined borders, and it prefers the flexural surfaces, like the inside of your elbow. These key differences are exactly what our toolkit helps us find. All right, time for a brand new mystery. Let's meet Miss S. She's a 46-year-old construction worker, and her case is going to bring a whole new set of clues to the table. So MS comes in with an itchy rash on her hands and feet. But the real clues are in her story. She wears these heavy steel-toe boots all day long, and then soaks her feet every single night. That should make a little light bulb go off in your head. We're talking about a moist environment. And check this out. Here's a fantastic clinical pearl. A real pro tip. When doctors see a rash on both feet, but only one hand, it's a huge clue. This 2 feet, 1 hand pattern is a classic sign. And why? Well, it's pretty simple.
People often scratch their itchy feet, and they transfer whatever's causing it to their dominant hand.
So what's the culprit? It's tinea, basically a superficial fungal infection. That warm, damp world inside Miss S's boots? It's a perfect breeding ground for these fungi called dermaphytes. They're these tiny organisms that just love to feed on the keratin and the outer layers of our skin, hair, and nails.
The treatment plan here is really a two-pronged attack. First, you've got the medicine, a topical antifungal like terbinafine to fight the infection. But honestly, just as important, if not more so, is the patient education. She's got to break the cycle by keeping her feet dry and changing her socks often so it doesn't just come right back.
So when you step back and look at our two cases, it's pretty clear, right? A rash is never just a rash. It's the body trying to tell us a really complex story.
I mean, think about it. We went from an internal autoimmune attack with psoriasis to an external fungal invader with tinea. The cause is way more than skin deep. And the big takeaway here is that by using a structured, step-by-step approach, doctors can actually read that story, decode the clues, and land on the right answer.
And that's a really powerful idea, isn't it? If a simple rash can tell us such a detailed story about our own immune system or our environment, it kind of makes you wonder what other stories are our bodies telling us if we just knew how to listen.